Hello friends, this is Dr. Ashish Taneja. So today I welcome you for the Conceptual Orthopedics Arthroplasty course. And my talk for today will be solving varus knee. I'll mainly focus on the surgical steps. So the varus deformity can be of two types. It can be intra-articular, which can be because of cartilage or bone loss, tibia vara, stress fractures, malunion or non-union of the intra-articular fractures of the tibial condyle. There can be other component to the varus deformity as well, like extra-articular deformities, which can be because of tibial fractures, femoral bowing or tibial bowing, some stress fracture, or a prior osteotomy. So we have to solve both these components together. Through our knee replacement surgery, our focus will be mainly on the intra-articular deformity, because that is something which we can correct through our knee replacement surgery. Extra-articular oftentimes do not need surgery per se, but if there are severe deformities which are deforming the biomechanics, then we may need to correct the extra-articular deformity as well. So how do you see what is intra-articular and what is extra-articular? You have to understand your angles, have to start drawing angles. So the intra-articular deformity is the angle between the femoral joint line, this one, and the tibial joint line. So this is your intra-articular deformity, which is mainly because of the cartilage and bone loss here in the medial compartment. For extra-articular or total deformity, you'll have to have a scanogram with you. Through scanogram, you will draw your mechanical axis of femur and tibia and angle between the two. That is your total varus deformity of the limb. If your intra-articular component is less as compared to total deformity, suppose this is 15 degrees and this is 22 degrees. That means there is 7-degree component of the extra-articular deformity as well, which will not be corrected by your knee replacement. So whenever your total deformity is more than the intra-articular deformity, you would suspect a extra-articular component as well. In our scenario, especially in Indian settings, there is a lot of patients who come with tibial and femoral bowing that will contribute to the extra-articular deformities. But again, mostly we do not focus on these deformities unless they are very, very substantial. So how do you classify these deformities? Varus deformity has been classified by Thienpont and Parvizi into 3 main types: intra-articular, which can be a reducible deformity, early stages. It can be an anteromedial OA or a posteromedial OA. You have to understand this clearly, that till the ACL is intact, it starts with anteromedial OA. The sequence of deformity, it always starts with a anteromedial OA, then the ACL gets damaged and the disease progresses to posterior. So anteromedial OA with ACL intact. Second will be posteromedial OA with deficient ACL. These deformities usually are reducible. The medial compartment deformities are reducible. You can just do a valgus stress and the deformity corrects because the MCL is not tight. However, when the MCL becomes tight, it becomes a fixed deformity. It can be without lateral instability or with lateral instability. When in the beginning, it is just the MCL tightness, but when the deformity progresses, the LCL becomes lax. That is when it becomes a lateral stable knee as well. This is the intra-articular deformity. Then we have the metaphyseal deformity. Metaphyseal deformity is within 5 centimeter of joint line, both on femur and tibial side. So you will see that the wear is extending to metaphyseal region. There is tibia or femur varus that is happening. That is the metaphyseal deformity. And diaphyseal deformity will be beyond 5 centimeter away from joint line. It can be tibial, femoral, or both. This is how it is. This can be an anteromedial deformity with intact ACL. This is the intra-articular deformity with posteromedial involvement with deficient ACL. How do we say it's a posteromedial involvement? It is this region. When the wear is in the posterior medial aspect, then we say that the ACL is now damaged and the disease has progressed to the posterior aspect as well. Then we have the fixed deformities, the fixed varus without with lateral laxity, and finally we have the metaphyseal or the diaphyseal deformities, which are within 5 centimeter or more than 5 centimeter away from joint line. So till there it is metaphyseal, and beyond this it is diaphyseal. And then there can be some previous osteotomies which will be a part of metaphyseal deformities again. These are deformities, these are osteotomies which are old healed osteotomies or old fractures which will cause a metaphyseal varus deformity. Now, for the varus knee, we have to understand the structures causing varus. Structures can be static or dynamic. So in the static structures, we have the superficial MCL, deep MCL, we have the posterior oblique ligament, PCL, and posterior capsule. For dynamic, we'll have the pes and serine tendons and semimembranosus tendon. The muscular part is the dynamic stabilizers on the medial side, and the other structures like ligaments and capsule and PCL will be the static components on the medial side. So these structures are mainly responsible for causing varus. So the MCL, the POL, posterior oblique ligament, the semimembranous tendon, the pes tendons, these are all the tendons and muscles are dynamic, remaining all are static. So you have to understand one rule regarding the release. Whenever we release the anterior structures right here, then we will affect the flexion gap. When we release the posterior structures, we will mainly affect the extension gap. So this is what you have to understand. Anterior release of the medial structures will help in opening the flexion medial gap, and release of posterior structures on medial side will help in releasing the medial extension gap. This is what you should be remembering. So as we discussed, that release of anterior structures will always increase the flexion gap, while release of posterior structures like POL, semimembranosus will increase the extension gap. Oftentimes, varus knee will always have a flexion contracture as well. And by releasing PCL, we will increase the flexion gap. So this is what you should be remembering. Release of anterior structures help in improving the flexion medial gap. Releasing of posterior structures help in releasing the medial extension gap. And PCL will help in improving the flexion gap. So this is a diagram which clearly states, this is the flow chart which states the effect of structures. You will see most of the medial structures affect the extension gap.